So first, we're going to start off with Lauren Hawkins, who's one of our pediatric nephrology fellows, joining us from Seattle Children's. And we already have your slides shared. Everything looks beautiful. If you want to go ahead and get us started.
Right. Well, thanks for having me here. As Daniel said, I'm one of the third-year pediatric nephrology fellows at Seattle Children's, and I'll be talking today about the impacts of prior authorizations on pediatric patients, bringing a little bit of spring or summer rather from a hike a few years ago here in this photo. Yeah, PowerPoint will participate. Oh, perfect. So today I'll be talking, we're starting with some motivation for why I became interested in this topic. I'll briefly review some of the history of prior authorizations, kind of how we got here. I'll give some background for what we know about the impacts of prior auths on providers, patients, and payers, and mostly more in sort of the adult population. Then I'll talk about some of my own work looking at the impacts on pediatric patients and the impacts on our patient population specifically um, here at Seattle Children's. And then I'll give some overview of recent policy updates and some opportunities for advocacy. So my motivation for this topic, or for learning more about this topic, came towards the beginning of fellowship when I was on a hike, just McClellan Butte, where you get some beautiful views of Mount Rainier up at the top. And so highly recommend it as a great summer hike for those hikers out there. And I was hiking with a friend who was a rheumatology fellow at the time, and while the hike was beautiful, some of our conversation was a little less wonderful. She was telling me about how she had spent basically a full day of her work week working on just one prior authorization for a child with JIA. And she described that this really was standard of care that she was trying to prescribe and first line treatment. So in her mind should not have been something that required a prolonged PA process. And this, I'd heard about prior authorizations being burdensome, but this was one of the first times I had kind of heard it from a colleague directly. And it made me frustrated and interested in learning more. As a fellow, I gained more experience with multiple patients in my own care and in our division in general. All in 1 week, we had a 9-year-old who was admitted with hyperkalemia, an 18-year-old admitted with transplant rejection, and I saw an 18-year-old patient in my clinic who was hypertensive, all related to issues getting their medications filled. It was unclear exactly how much prior authorization specifically played into them not getting coverage for their medications. But it was very clear to me that there were significant barriers in terms of providing adequate and really standard of care to our patients, and that prior authorizations were one piece in that puzzle, making it more difficult. So I started looking more into this topic. And so a brief review of prior auth history. It began essentially with utilization review when Medicare and Medicaid were created in the 1960s. This was more typically used for review of hospitalizations and appropriateness of hospital stays, but it expanded in the 1980s with prior authorizations, mostly as we know them today for medications and services. This also included formulary restrictions and tiered patient cost sharing. Over the past couple decades, we've continued to see use of PAs grow. And this has been both in public insurance and commercial formularies. Multiple studies show that there's been a significant increase. I was sort of surprised and impressed to see how much that increase has been. In one report of drugs covered by Medicare Part D, that increased from 8% in 2007 to 24% in 2019. And then in a report of a subset of drugs and commercial formularies, but across multiple drug classes, showed an increase from 35% in 2011 to 67% in 2016. So it's not just all in our heads that it feels like this is a bigger burden than it used to be. So I wanted to hear a little bit from the group just about what impacts you all have seen and experiences you have had with prior authorizations. I have a poll, that if Alyssa could help me pull up, that would be great. Awesome. So I'll give you a little bit of time. So first question for your patients whose treatment requires a prior authorization, how often does this process delay access to necessary care? We have options from always to never. And then second question, has the PA process ever led to a serious adverse event, including hospitalization, life-threatening event, death, um, or death for a patient in your care? So yes or no. I'll give everyone a minute to respond. Then, Alyssa, if we're able to share those results, that would be great too. All right, great, thank you. So you can see most people have seen that prior auth does lead to delays in care, at least sometimes, with more than half saying often or always. I'll share some results from kind of national studies or national surveys, and this is pretty in keeping with what providers across the country have said. Similarly, about 1/4 of folks have said that prior auth has led to a serious adverse event for patients. And that, again, is similar to what we've seen nationally. Thanks, Lisa. Alrighty. So again, here are results from an AMA survey back in 2022 asking those same questions. So I'd say pretty similar results here with 94% of providers reporting delays in care associated with prior auth at least sometimes, and a little over half seeing it often or always. 33% of physicians reported that prior auth has led to a serious adverse event for a patient in their care as well. The survey also looked at more of the provider experience and the burden that is placed on the practice. So on average, they found that practices complete 45 PAs per physician per week. I wondered if this graphic was trying to say 4.5 with this stack of papers, but I looked into the survey results in text form, and it is truly 45 PAs per physician per week. They also reported that physicians and their staff spend about 2 business days per week completing PAs, and 88% of physicians describe the burden associated with prior auth as high or extremely high. So it was interesting to see these numbers, and also thinking about both the patient outcomes and the provider burden and outcomes as well. So I want to learn more about, what we know about the impacts on our patients, and just a sort of brief review of some evidence in primarily adult patient populations. These studies have reported that PAs are associated with decreased medication adherence, increased healthcare utilization, delays in care, and adverse clinical outcomes, including asthma exacerbations, steroid exposure for rheumatologic conditions, and decreased disease improvement for skin conditions. And I'll get into a little bit more detail with some of these associations in the pediatric population. I want to highlight one of the studies. Was a systematic literature review, primarily looking at adult studies, but with a few pediatric studies included there. And this is by Park et al. In 2017. They looked at both, so they reviewed how studies reported both patient and payer outcomes associated with prior authorization. And so you can see through this graphic, which I found very telling, I suppose, that here on the left side are what studies reported were patient outcomes associated with prior auth, and then on the right, what were payer outcomes associated with prior auth. Like the graphic, because the color coding makes it very easy to interpret just by kind of glancing at it. So you'll see that blue and green represent negative outcomes associated with prior authorization, and then orange and red represent positive associations, with the sort of intermediate colors being studies that had non-significant or unclear significance of their statistical significance of their findings. So I just want to highlight here is that over on the left side with patient outcomes, you can see that um, uh, these areas are much more blue and green, so representing more negative impacts of prior auth when it comes to the patient. And the colors are much more red and orange on the payer side, which is perhaps not surprising for what we know kind of anecdotally about um, who benefits from prior authorization. I want to highlight one study just to be not quite too negative about prior auth throughout this whole talk. This was done in 2023 by Brock Goldberg et al., which reported a net financial savings of about $86 dollars per beneficiary year um, associated with prior authorizations. This was looking at a Medicare data showing $96 in savings for beneficiary year versus only $10 in the cost of paperwork or the administrative care work. Um, I don't know how well this applies kind of to all patient contexts and all practices, but I do think it was important highlighting that even accounting for the administrative burden, at least financially, there is still potentially some benefit. So this all made me want to think about, how do prior auths specifically impact pediatric patients? So with the help of Dr. Paul Fishman, who's an economist in the School of Public Health at UW, we did a scoping review of the clinical impacts of prior auths on pediatric patients. We started with 287 studies and made our way down to 11 that were included. And these were excluded a good number just because there were duplicates. Some did not end up actually having much pediatric data within them. And then some didn't really evaluate patient outcomes, but rather were looking at provider burden or economic outcomes. So of those 11 studies, 2 were case reports or series, 5 were cross-sectional, mostly surveys, 1 qualitative, 2 were retrospective cohort studies, and 2 were natural experiments. So overall, fairly descriptive data and not particularly quantifiable, which is part why we did a scoping review rather than a systematic literature review where we could kind of summarize data a bit more. So of these studies, we found that most of them reported negative outcomes associated with prior authorizations. So 9 studies found primarily negative outcomes. This included delayed or missed patient care, adverse clinical outcomes, including increased seizure frequency and increased steroid exposure, increased healthcare utilization, and patient and caregiver distress, including anxiety about whether or not the medication would get covered, missed work and school, and increased time on the caregiver's part trying to process or get the medication covered. When it comes to patient outcomes, 2 studies reported neutral outcomes. One of these also reported positive outcomes in terms of financial savings, but focusing just on the patient outcomes here, these really showed neutral impacts. And so 2 studies showed no increase in disease-related healthcare utilization after PA implementation. This was for pelabresumab, which is sort of the first generation RSV monoclonal antibody, and montelukast. I want to focus on one of these studies in particular, which was one of the more robust studies included in our scoping review. This is titled Delays Related to Prior Authorization in Inflammatory Bowel Disease by Constant et al. In 2022, published in Pediatrics. This was a retrospective cohort study looking at pediatric patients with IBD who had been recommended a biologic therapy at their single center. The exposure of interest was prior authorization requirement. And then their outcomes were looking at time from physician recommendation to the first dose of the medication, IBD related healthcare utilization at, I believe, 1 month, 3 months, and 6 months from recommendation, and steroid exposure at 90 days from recommendation. Their methods included multivariable linear regression for the first outcome and propensity scoring for the second 2. Their findings included that when it came to time from biologic recommendation to initiation, prior auth was associated with increased time to initiation, They subdivided their exposure of prior auth into uncomplicated, meaning there was no denial process or no peer-to-peer needed, and complicated, meaning that there was a denial and a peer-to-peer or letter of appeal was required. Compared to not having a PA, uncomplicated PAs were associated with a 10.2 day increase in initiation time, and complicated PAs were significantly longer, 24.6 days longer. When it comes to sort of clinical outcomes for patients, essentially as they were waiting to receive their medication, IBD-related healthcare utilization at 30, 90, and 180 days from recommendation was associated with higher likelihood of healthcare utilization. And so just to kind of focus your attention on all these numbers here, PA was associated with a 5.9 to 12.9% higher likelihood of healthcare utilization at these different time marks from the medication recommendation. Similarly, corticosteroid dependence was associated with a 14.1 higher likelihood of steroid dependence at 90 days from medication administration with a prior authorization. So this all made me want think about, how are our patients in pediatric nephrology affected by prior authorizations, and kind of using the constant et al. Study as a bit of a model. I wanted to look at our patients who receive infusible medications. So with the help of Dr. Ari Pollack, we conducted a retrospective cohort study looking at our patients who received an infusible medication for a nephrology-related indication from October 2020 to October 2024. We chose this starting date because that's when we switched over to Epic from Cerner and figured that would make sort of data extraction a little bit easier. So our exposure of interest was prior authorization requirement. Our outcome was time to medication administration. For our analysis to compare prior auth versus not, we did Cox and Rank sum test, Human Whitney U test. Within that analysis, we looked at the group overall, as well as within sort of dividing out public and private insurance patients. And we had a change in the scheduling system for infusions in October 2023, so 3 years into our time frame. We used to have the medication ordered and get the infusion scheduled before the prior auth was necessarily approved. Now we require that the PA gets approved first, unless there's an urgent indication. And so primarily for giving some feedback to the infusion unit, we wanted to compare those two timeframes. So some of our patient demographics from our study, we had 143 patients with 255 unique encounters. Our patient demographics showed a little less than half female sex assigned at birth, 46.2%. Median age was 13 years, and a little over half had public insurance. Looking at the encounter level, 60% required a prior auth. There were 21 medications and represented, with rituximab and IVIG being the most common. And there were 26 indications with nephrotic syndrome, transplant rejection, and positive DSAs being the most common. So here are our kind of main results. I'll draw your attention to this sort of central line and this forest plot, which was our overall association. So throughout the whole population, or all of the encounters rather, there was a 11-day increase in time to medication administration associated with prior authorization requirement. This finding held across different subgroups. So draw attention to the insurance groups. So both in private and publicly insured patients, there was an increased time to medication administration that was more pronounced in the private insurance group, which I found interesting, but we have not necessarily explored all the reasons for that yet. The old scheduling system had a similar association as the group overall, which is perhaps not surprising because there's just more time, more encounters included in that group. Interestingly, the new scheduling system, where we wait for prior auth approval before scheduling, did not have a significant delay associated with prior authorization, which may indicate that the new scheduling system to some extent mitigates the impacts of prior auths. But as you can see, the confidence interval is quite wide, and so I think a big part of this is simply that is the total number of encounters included in that group. If we continue to do this work and look back in another year or 2 years, we may or may not see a difference. But that was helpful for me thinking about ways we can, without necessarily changing prior auth requirements, can change institutional practices to help mitigate the impacts. Alrighty, so I wanted to talk a bit about some policy updates, things that have already been happening, and space for advocacy as well. So in Washington State, just last month, a bill was signed into law that limits insurance use of AI for prior authorization denials. It requires that a person, a human at least, reviews an AI-generated denial. It also prohibits retrospective denials. There have been a lot of laws already passed or in legislatures across the country seeking to do similar things. To my knowledge, just to kind of calm any worries, none of these are limiting AI use for generating letters of appeal. It seems to be primarily for limiting automatic insurance denials. Last year, CMS released a final rule that requires uh, Medicare and Medicaid to provide more clear reasoning for denials and shortens the time frame for response. And so this, of course, only applies to public insurance, but sometimes can be used as a model for commercial insurance as well. I want to highlight a couple of resources for what you can do. So first, just staying up to date on PA requirements and legislation that has already passed, I think is helpful to know, what wins have happened, or if, you feel that legislation has not been adequate or is not appropriately addressing issues. Um, and then also sharing your stories, both when insurance agencies maybe don't meet those legal requirements, and simply sharing stories of when prior auths impact patients and what seems to be an inappropriate way. This top QR code is for the Washington State Prior Auth Navigator. This is a great website that I found in the process of making this talk that kind of reviews recent legislation that's coming up, and also provides a link to report if an insurance agency is not meeting those requirements. The second QR code links to a general AMA prior auth topic page with lots of information about what's going on at the national level, what the AMA's kind of policy focuses are. And also through that website, you can get connected to another reporting tool that allows you to share sort of general stories about how PAs are impacting your patients. So some conclusions. I found that prior authorizations impact patients and payers differently, which is perhaps not surprising. I think there's not necessarily, or there may be benefits of prior authorizations to patients, but from what we can see, the financial benefits to payers do not clearly get passed down to patients. And it's fairly clear that the clinical impacts on patients are primarily negative. In our patient population specifically, prior auths are associated with delays in care. And prior auth policies have changed since their inception. There are some restrictions happening, which may or may not translate to kind of impacts on patients in our own practices as well. And there's more work to be done. So first, I want to give a big thank you to some of my advisors, Ray Pollock, Paul Fishman, Joseph Flynn, and Jody Smith, who've been part of my SOC, Sam Ching, who helped with data extraction. And these are a couple of photos. I've gotten to do a few advocacy days in the past year in DC, getting to know some folks in the sort of adult nephrology world, as well as general pediatricians. It's been great partnering with those folks. Um, I'm happy to take any questions.
ask a question if
Yeah,
there's
happy
time. Yeah, Lauren, thank you. I imagine you don't have the time, in this talk to wade into the
to.
whole, comparison with other health systems, like in the UK, where they have, a integrated health system, and you know, a, I think a lot of the problems that you're seeing are very deep rooted in, what our health system is in the US. Do you see a way to, do away with prior auths in the US, or is it more about making it them incrementally less burdensome? What is
Right.
your big picture view on this topic?
Yeah. I mean, I think me personally very much have ulterior motives of getting rid of prior auths or nearly doing that by the end of my career. Realistically, I don't think that's going to happen. And I also, I'm not an economist, and so um, that may not be the best answer. Um, I think so. I will be taking my first faculty job down at UC Davis later this summer, and I've learned through that process that California has can't remember what it's called now, but for their pediatric patients, they have a special program within Medicaid for any patient who would otherwise qualify for Medicaid and has a complex medical condition. So that's quite broad and thus encapsulates a lot of our patients. Um, there's sort of this extra coverage, and those patients essentially almost never require prior authorizations for treatment or medications and have a little bit easier access to wraparound services. So I think that program is something I'm not sure how well studied it's been and compared, but I think that would be a really great model, to be within our own country and within otherwise kind of similar healthcare system, but with that one difference, I think would be is a good model for, how do we expand this to a broader population? Um, you know, that may not be comparable to the general public, but I think using those kinds of models and testing those in those types of populations is at least a really great way to start so that we're reducing the barriers, to those vulnerable population.
Thank you. Any other questions? First of all, can you guys hear me? I got a message that my mic was, you
Yes.
can, okay, perfect.
Yeah.
Um, thank you. Any other questions for Lauren? Okay. Well, we certainly can continue any further discussion in the chat. Thank you so much, Lauren. Really appreciate your time and a wonderful talk this morning.